Second, I'm Mark Goldstein. I'm the president of the hospital. With us, you just heard from Danielle. She's our vice president of strategic planning here at the hospital. Kevin Kilday, our CFO, Dr. Gail Sayer, our chief medical officer, and Dr. Peter Sebeny, who runs our entire infectious disease program. We've been blessed over the last 549 days, if you can believe it, since we hit that special day in March when we learned that that COVID was going to hit us hard. It's incredible to think about the journey that we've been on over those last, what is now almost 19 months. To the very beginning, when there was so much, we were unsure of so many different parts of the virus and what was it heading for, and then all of the shortages and the grind that we had in that first wave, taking us through March and April, and kind of that lull period we had over that first summer to a roaring back virus in January, and then the introduction of vaccines, which really completely changed the way we all approach it. And what you're going to hear today from Peter is a lot of facts, and he's going to be able to do some Q&A. I see a friendly face, Becky. Nice to see you, Becky. So glad you joined us. And you know, Peter's been by our side every step of the way throughout this process. He not only helped AJH, but he was a leader in the BILH system and was able to really provide a lot of thoughtful advice and guidance and be part of a team. Because the way we really approached COVID, it was as a system. And we are thrilled to be in a position right now where so many of our employees have been able to find their way to the vaccine. You know, I was just looking at some statistics. In Massachusetts, we're the leading state for vaccines. Massachusetts and Vermont, leading states on eligible people. There's roughly 6,100,000 eligible people for the vaccine, and we have over 5 million people vaccinated. Now, it's easy to talk about the people that are vaccinated, but what we're going to do today is obviously talk through what our main driver here is to get the information out to everyone here, especially people that are leaders in the organization, so that they can help with their colleagues, their friends, their family, and be able to talk to them about the risk and the reward and the safety of the vaccine. And without further ado, I'll introduce Dr. Peter Sebeny. And again, since it's such a small group, if anything pops up in the small group, in the larger group, we weren't able to really take questions. But since there's only 3 employees currently on the list today, please feel free to interrupt and ask questions as we go along. With that, Dr. Sebeny?
Yeah, thank you. Thanks, Mark, for those kind words. So yeah, we did this the other day with a larger group. Actually, Mark, since it's a shorter group, I'm going to suggest that we go around the room and ask you guys all questions. No, I'm just kidding. I don't want to put anybody on the spot, especially since you heard that this was recorded. But yeah, many of you probably don't know a lot about me because, you know, when I came to AJH 3 years ago, we kind of hit the door running, so to speak, and then COVID shows up. But I happen to have a lot of experience in vaccinology and clinical trials in my prior life, which I'll touch on a little bit. You know, in the early days, I'm lucky to have the support of BILH, and you know, we have some experts at BILH, such as Sharon Wright, who is now, as many of you know, this Chief Infection Prevention Officer for the system, which she has been really critical. You know, sadly, I have yet to meet her in person. That's how crazy it is. You know, I probably have heard from her, you know, once every week or two, and certainly Patricia once a week. But yeah, we do manage this as a team, and I'm thankful to have a team and your all support as well. So without further ado, you know, before we get started, you know, there are still so many, you know, this is geared towards employees, but it's really the community and our loved ones, as well as if you're, you know, serving in patient care, our patients. This is one of the most important issues. I said this the other day, and I do want to say it again. I've spoken for industry and for academia on vaccines, historically influenza vaccines. And sometimes an analogy I like to give is certainly for influenza vaccines, as we use an analogy of seatbelts, right? You know, generally it's an accepted standard to wear seatbelts. People don't necessarily anticipate getting into a car accident. Seatbelts, we know, save lives. They help prevent serious injury. You can still get into a car accident and potentially get injured. You still could lose your life, but seatbelts, time and time again, have shown to greatly reduce that risk of injury and death. And it's something that we pass on. We encourage our children to do it. We encourage our loved ones to do it. And the influenza vaccine can be considered really in the same way. You know, of course, COVID now comes along with massive numbers of cases, massive clusters, such a density of disease around us. It is actually more scary. I remember Gail and I talked about this a number of months ago, and it's kind of like not wearing a seatbelt, but also, you know, driving on a highway during an untreated ice storm with bald tires and, you know, your family's in a bicycle next to you. I mean, so we really owe it to ourselves and our families to really protect all of us, our community. And honestly, as an organization, you know, sharing knowledge, being transparent, and really trying to improve vaccination rates is really going to improve our resiliency, which is constantly being tested. Okay, so let's go ahead and get through this presentation. And by the way, I want to just thank Danielle and Kelly Sullivan for helping to put this together. I often do a lot of PowerPoints, but I unfortunately had no time to do these, and I'm very thankful for them putting this together for me. So if you don't like the slides, don't blame me. I'm just kidding. Anyway, so we're running into this problem, folks, and you know, unfortunately, the virus has outsmarted us, and we did not reduce disease incidence. We've had problems with emergence of variants, and so now we're dealing with the Delta. This slide depicts data from July, which by then about the United States is about 80% of all the COVID infections are Delta. Delta has taken over the initial strains of COVID. And what we're seeing even now, despite arguably some diminution over time and potentially with the variations and new mutations, is that, you know, vaccination still reduces COVID infection by more than 8-fold. And this slide describes from the COVID tracker, the blue is fully vaccinated, green unvaccinated, that you have an 8-fold reduction in incidence of disease still, despite Delta, a 25-fold reduction in both hospitalization and death. So there are still some people with breakthrough infections. Those are people who get vaccinated and still can get a COVID infection. And we can talk about that. We're seeing a little bit more of that also because probably of what's called immunosenescent, particularly in our immunocompromised. But without question, despite the predominance of Delta circulating in the community, the vaccine is still overwhelmingly effective. Okay, next slide, please. We're just going to go through these myths. The NFID is one site that people can go to. You can also, CDC is wonderful. The Advisory Commission on Immunization Practice, which then feeds into CDC. Their meetings are publicly available. Their slide decks are publicly available. And so there's a lot of information out there on it. NFID is another nonprofit organization. Our society, IDSA, Infectious Disease Society of America, has lots of information, whether you're just a layperson or, you know, a public health person or just, or even a provider. There's a lot of information out there. And I just want to be very explicit about this. This is one of the most challenging issues, is there's so much misinformation, conspiracy theories. I hear them every day because I ask every single patient in every single setting. And there's almost not a single day goes by that I don't hear a conspiracy theory. Anyway, so the first myth is COVID vaccines can be dangerous. What we're going to show you is that they've gone through extensive safety testing in multiple clinical trials with thousands of individuals. And the benefits of the vaccine overwhelmingly outweighs any potential harm. If we can go to the next slide. And I actually added this slide because there's been a tremendous number of sort of proof in the pudding. You know, there's never been a quicker rollout of a vaccine, as well as a large number of people obtaining it. So the data we have now is great, excellent data. We know that over 5.7 billion doses of COVID vaccine has been administered all worldwide, although it's been very disparate. where folks have been getting vaccinated, and that obviously raises an issue about public health equity. Even in the US, when we look at just doses, of course, realizing mRNA vaccines are 2 doses, 380 million doses have been given thus far, and 170 million of the US is vaccinated. So you think about that number of people who've gotten vaccinated, you know, there's a lot of data out there. Next slide, please. And I want to say that there is no question the COVID vaccines that have been licensed, either under EUA or now with the Pfizer vaccine having full FDA approval, it is unprecedented how much vaccine safety monitoring there's been in the US. So there's systems, complementary systems in place that I'll just highlight very quickly. And there's just millions of people in the United States who've gotten this vaccine. So really, the safety of this vaccine is actually very well documented. And we'll talk about that. This is a list of 4 of these. They're somewhat out of order, but go ahead and go to the next slide. The first one is VAERS. This is actually publicly available. This is the Vaccine Adverse Event Reporting System. This is a nationwide system. It's been there for many, many years. This also is a key system that identifies anything that happens post-marketing, so post-licensure. Sometimes there's rare events. Studies can involve tens of thousands of people, but if there's something very rare that occurs 1 in a million that might or might not be related, VAERS typically has captured that. I do want to make one thing clear, because I think this is actually really important as we think about things. And I have to talk to a lot of people, including doctors, about this. And this is sort of the human condition, right? I mean, we all have inherent bias in our decision-making and our thought processes. One of these is this inherent bias of causation and cause and effect. Sometimes we think when things happen, at time A, and then, time B, this then happens, and then this then happens, we tend to over-correlate them as causational or having some other relation other than being sequential in time. And you have to be very careful when you look at adverse events related to vaccine, right? We know with how many times you hear about people who say, oh, I got the flu vaccine, but it gave me the flu. And of course, that's scientifically impossible with any of our attenuated vaccines. What they may have had is some local side effects from the vaccine, which is what is normal. It shows that the vaccine works because in order to prime the immune system to make antibodies, there's a cost to pay, and it's local reactogenicity at the injection site, for example. Other people would say, oh, but then I got sick 2 weeks later, so it made me sick. Again, that gets that bias where things that occur over time may not be related. And actually, the FDA and safety experts always allow that bias to be implicit. In other words, it's hard to exclude that when you look at these databases. So, I don't think there's anything being sort of underreported, generally speaking. But VAERS has been there for decades and very important. There's this new system, the Clinical Immunization Safety Assessment Project, which you see here. Major medical centers with international experts from academia. These aren't all government employees. Boston Medical Center is one of these. That is one of the other complementary systems in place. Next slide. There's also a vaccine safety data link. This includes 9 participating integrated healthcare associations with 12 million persons being studied per year. Harvard Pilgrim and CDC and Kaiser are all part of this. So these are 3 of the systems. Next slide. And of course, some of you may know about vSafe. This was sort of the latest and greatest that was developed specifically for COVID. This has been very informative. Actually, we'll talk about safety and pregnancy. This is a novel, complementary data gathering to really assess safety of vaccination. So again, with the sheer number of people getting vaccinated over a short period of time in the midst of a pandemic, having huge data systems in place, I think what you're seeing with the track record is clear. There's no, there's really no signals that are being suppressed about safety. And we'll go through that in a little bit more detail. We know that there are some side effects from vaccination. They are extremely rare. And when you actually put this into a risk-benefit model, when we talk about the severity of COVID, the unpredictability of COVID, and the potential long-term effects, there is no question that even with these side effects, the benefits far, far outweigh. So for folks who have a risk of anaphylaxis, there has been a few cases of anaphylaxis. The risk is thought to be 2 to 5 per million. That has been well mitigated by folks, having EpiPens available and by being monitored for 15 to 30 minutes afterwards, sometimes 30 minutes or longer if there's a concern. And so we know that going into this. And so that's been well mitigated. There's been a rare occurrence that of myocarditis and pericarditis. Thus far, it's looking at about 2 per million. This has been associated with the mRNA vaccines. I can tell you that in most cases, this is in young males, usually 20 to 40, and is not generally severe. But there are very special exceptions for those cases. But again, it's extremely, extremely rare. There's been this hint of, and possibly in association with thrombosis and thrombocytopenia with the J&J vaccine, thought to be maybe three cases per million. I can tell you that in folks with a history of platelet problems or blood clotting problems, generally we're advising them to use a different vaccine product. This one is still being vetted, by the way. And then the last one is GBS, Guillain-Barré, which is very complex. I could talk for hours on this, but it's very rare. It actually it is thought to be extremely, even more rarely associated with the influenza vaccine. Unfortunately, there's a lot of misinformation about it, but it has been associated with the J&J vaccine. But again, it is extremely, extremely rare. When you compare this to being struck by lightning, where it's two cases per million per year, hopefully, if we can get to maybe 2 or 3 vaccine doses, I hate to say that, but let's just say, when the risk is, really minimal. And by the way, with COVID-19, you're much more likely, as you see down here on the bottom, to actually get myocarditis or pericarditis from the actual disease, right? 100-fold greater risk. And the same is said for thrombocytopenia and thrombosis disorder, also found to be associated with COVID. And by the way, the same thing is somewhat true about influenza vaccine and Guillain-Barré. The association with influenza and GBS, Guillain-Barré syndrome, was anecdotally made in 1976 during a swine flu scare. And it's been studied over several decades since then. And there possibly is a very small risk. But guess what? It is still so much more common to get Guillain-Barré from a viral infection like influenza than it is to get it from the influenza vaccine. So again, all of these things are well documented. The risk is exceedingly low, and the benefit far exceeds any risk. Next slide. So, we always wondered if, we were going to have a second and third surge. We definitely need better vaccination rates in the United States. It is also very geographically based. Certainly, we can't make promises about what happens in the future. We always kind of thought early on in modeling that the coronavirus will continue to circulate seasonally, but so far the vaccine is still covering the current variants, and that's great. But there's a lot of research being done. I think I've said that sort of all the research, all the trials, all the journals. You're in my home office, and I can tell you it's a mess. I have feet and feet of journals. I tear them out. I'm a junkie reading these articles, and it's like drinking from a fire hose. So anyway, but let me just tell you something. We've had vaccines for 80 years. Billions and billions of people have gotten multiple vaccinations. One thing that people don't know that, and the autism MMR thing has been readily debunked multiple times. And actually the FDA talks about this. Even though we went through 3 months and 6 months and had the EUA with all that data, and now the Pfizer's has full approval. There's only one instance in U.S. history that I'm aware of, and that experts are aware of, where the vaccine caused a side effect more than 6 weeks after receiving the vaccine, technically after 3 months. And that was a case of polio transmission when we used to give the oral polio vaccine. That is the only one. So every side effect ever known to be related to a vaccine in U.S. history has always occurred early. So there's not any new surprises. I know people talk about the mRNA vaccine, and we'll get into that. But so therefore, in addition, because of that track record, because of the research, And because of all the other trials done on multiple other disease states and vaccines, there's really no plausible biological possibility to expect side effects that develop months or years after vaccination. Meanwhile, as many of you know, many people, even young, healthy people, are still not themselves sometimes many months after the COVID infection. And the treatments, by the way, are not great. It's a very discouraging disease to sometimes manage because you feel like sometimes you just can't do enough. And by the way, mRNA vaccines have been studied in humans for many, many years. Actually, I have an old colleague of mine, Dr. Kester, who now is at Sanofi, who was an Army Colonel, ID doc, great guy. Ironically, he and several colleagues published a narrative review of mRNA vaccine technology. No kidding, in like October, November 2019. It's in a prominent vaccine journal, and it actually highlights this technology as being wonderful for rapid development and deployment of vaccines. And it actually highlighted how many times it's been studied in over 20 US clinical trials over multiple disease states and has been safe. And I'm happy to share that with you if anyone would like to see it. It's very tech heavy, but it really demonstrates that this is truly not it's not a novel technology, although it's a wonderful technology and we're very blessed to have it. Another common myth is that if you've already had COVID-19, you do not need to get vaccinated. This is a myth with other diseases. One of the problems is don't get me wrong, with having a natural infection, you develop natural immunity, but in many cases, the natural immunity is not as durable as the immunity offered by vaccine, and that is what is sort of bearing true at the present time. Next slide, please. This is a study in the CDC newsletter MMWR just from August, that people with a history of COVID-19 are still better protected from reinfection when they are vaccinated afterwards. And what you see here in this table, case controls design, that they were, those not vaccinated were 2.34 times more likely to actually develop a true reinfection than those who ended up getting vaccinated after the infection. And really, that is, it's like 2.3 times more likely to develop a reinfection if you somehow choose not to be vaccinated. Next slide. And that's just a simple study. I mean, I think this is going to continue to bear out in other studies as well. Another myth, and this has been very complex early on, and I know there have been many pregnant women as well as women of childbearing age or wanting to become pregnant who are a little bit wary of the vaccine, particularly the mRNA vaccine. That is also a myth. So the CDC and multiple agencies have recommended that they get vaccinated. Unfortunately, pregnant women are at increased risk of severe illness from COVID and death, including sometimes fetal demise. We know this is true with influenza. And I can, unfortunately, I know of many travesties with influenza in pregnancy. It's a high risk situation with viral infections in pregnancy. Next slide. CDC, ACOG, American College of OB/GYNs all recommend that pregnant folks, those wishing to become pregnant, including those breastfeeding, all are recommended to get vaccinated. This has been recommended across multiple agencies. And it actually does apply to all vaccines, whether it's the traditional Johnson & Johnson vaccine or the two mRNA vaccines. Remember the V-Safe program I described? I can tell you one of the problems about this, as you know, and the same could be said for young children, is in clinical trials, it is sometimes more challenging to do them upfront with young children as well as with pregnant folks. And this happens all the time with drug development as well. But I can tell you there's been a study in New England Journal of Medicine, it's somewhere next to me, by the way, from July 2021, that really demonstrated among a review of 35,000 pregnant women who had been vaccinated, there was zero safety concerns compared to those who were not vaccinated, but specifically regarding fetal risks, spontaneous abortions. And again, that information is readily available. But we do know that unfortunately, if you do get COVID, you're at higher risk of becoming ill and infecting families and friends, and it's at putting risk to the baby as well. And again, I recommend that folks that are pregnant, breastfeeding, or wanting to become pregnant, have questions, talk to your OB/GYN, talk to your provider. I'm happy to sometimes get some discussions about this, but if you have some today or know of some, bring them up here at the end. Part of this issue up front came from the UK. UK and Israel started mass vaccination a little bit earlier, and the UK Health Authority initially did not recommend pregnant folks to get vaccinated. But obviously, as the data became very clear, this is where I think we have more work to do in convincing folks. Next slide, please. Okay. The current vaccines will not protect against new mutations of COVID-19. Thus far, with the Delta becoming the predominant strain, we are still seeing that it is still extremely effective. The effectiveness may have fallen off a tiny bit. I can't predict what's going to happen in the future, but the vaccinologists are constantly looking at these variants and trying to map these things out in case we do need to make another vaccine. But I can tell you that the current COVID vaccines continue to be extremely effective against Delta, as well as some of the other variants that are in other parts of the world. Just to mention something about breakthrough cases, as you know, the Delta variant currently represents the majority of the COVID types that we're seeing, as well. Massachusetts is no exception. This is data from mass.gov looking at cases through August 26. And when we mean breakthrough cases, we're talking about COVID infections that occur in someone that's fully immune, which technically means 2 weeks after the J&J shot or 2 weeks after completion of the mRNA 2 vaccine series, if you will. And yes, there's been a number of them. I'm aware of a lot of them, actually. There's been close to 10,000. It represents about 0.23% of all those vaccinated. And there has been 444 hospitalizations, representing 0.01% of all those vaccinated, and 106 deaths, 0.002%. What I tell people, again, I ask every patient, and I know, I somehow know about every COVID patient at Anna Jakes and another hospital. And I can tell you my experience with almost 200 patients that have been hospitalized. I know of about 6 or 7 as of now who have fully were vaccinated and thus had a breakthrough case. Unfortunately, I know of at least 3, if not 4, who have passed away. Unfortunately, all those patients were unfortunately profoundly immunosuppressed. So they did their duty, they got vaccinated, they got it early. So many of them were done by March or April, but they still succumbed to the disease. By the way, this is one of the reasons why we still are masking despite being vaccinated, is there still is a little risk of breakthrough case, meaning sort of like symptomatic, but there is a little bit of asymptomatic carriage that can happen. And that's why we're still masking, because there is still a lot of density of disease out there. Next slide. People with allergies should not get a COVID vaccine. That is a huge myth. Actually, like I said, I've never seen so much transparency out there. And at the same time, I've never seen so much misinformation out there. And that is, every single ingredient that's in either of the 3 vaccine products is listed down to the chemical structure. There's no egg products, so we don't have to discuss that. Even egg with influenza vaccine is mostly a myth. But really, people could see an immunologist if they've had an allergy to a COVID vaccine, but really there is not folks that have food allergies or antibiotic allergies that can't get a COVID vaccine. And again, we're always looking out for this, and people are under observation after they get the vaccine to monitor for any of the significant allergies. Next slide. Next. I had to address this. I pulled a fast one on my kids even on this one, but there's a lot of myths about being magnetic, but there's no metals, microchips, or other ingredients at the site of injection. It's almost hard to entertain this, but yeah, there's been a lot of misinformation about this. Next slide. Yeah, these are kind of complementary, and One is that, oh, well, we're worried that COVID vaccines, and again, I hear this mostly from mRNA vaccines, can affect fertility. But there is no evidence suggesting that fertility problems are a side effect of any vaccine, including the mRNA vaccines. And as you know, as I talked about, it is certainly recommended. And to be honest, generally, it's always better to get vaccinated, before you plan pregnancy, right? I mean, what happens if you get pregnant and you get COVID, soon after? Even problems within the first term of pregnancy can happen with COVID. So definitely get vaccinated. Next slide. This one, yeah. So the mRNA vaccines do not affect your DNA. Again, it sounds scary, and I think the problem is there's too many people who have a lot of social respect and social platforms that are misleading the public. And mRNA vaccines do not affect or interact with DNA in any way. This is messenger RNA. It does not incorporate into chromosomal or nucleic DNA, so it cannot combine to change genetic code or create what's called genetic imprinting that can be passed on and that type of thing. Actually, the mRNA vaccines are sort of they're sort of equated to being like the Snapchat of vaccines. You literally put in what is essentially a blueprint, okay, that tells your body to make the antigen, to make the antibody, and then it's gone. It's gone. It's very stealthy. Anyway, so and again, I'm happy to provide, if those who are inclined scientifically have questions, I'm happy to provide them with some literature on the science. And CDC does have some good resources as well, of course. And of course, you cannot get COVID-19 from the vaccine. This is incredibly common with influenza vaccines. Sometimes I have to insert the issue of bias, right? So let's just face it, we all know people who got the first shot, they might be waiting the 2 to 4 weeks for the next shot, and then they get COVID. And again, your natural instinct is, did that vaccine give me COVID? Because I told you about the human condition and bias. And of course, that's not true. So sometimes people think this because they've gotten COVID after the first dose or the second dose, that it is impossible. It does not contain live virus. Some people, as you know, many of us who have been vaccinated, hopefully, particularly with the second mRNA vaccine, yeah, you get reactogenicity. You expect that. Arm pain, sometimes body aches, sometimes fevers, malaise. A lot of us had that, but we knew to expect that. And I think as we talk to our loved ones, that's the proof that that's the cost it takes to get immunity is when your immune system gets revved up from a vaccine, that's how you protect yourself. Just like with severe COVID, I tell people sometimes it's not, when someone gets a COVID infection, the most highest concentration of virus is in the first, 7 days to 10 days maximum. And that's why the antivirals aren't that effective in some ways, because by the time they get really sick, the virus has already done its damage, because it's after that is the inflammatory response in the body. And so with the COVID disease, it's actually the inflammatory response that is making people so ill. We definitely want to avoid that. And if the cost is getting vaccinated to have a little bit of local reactogenicity, which is nowhere close to what most people deal with when they get infected, even if they never get hospitalized, again, it's well worth the risk. Next slide. I'm going to stop there, but as you know, Matt Bennett with HR is available. Karen Dieselman, who definitely deserves a lot of kudos, as does obviously Patricia Lawrence, who've been out on the front line with this. BILH Employee Health, I think, has been really been ramping up, and I think has been pretty stellar with this. And of course, there's an employee assistance program as well with the website you see there. I